So 3 studies have been conducted looking at the CDK4/6 inhibitor Trilaciclib for myelopreservation in small cell lung cancer. The core concept here is that chemotherapy causes myelosuppression, which causes suffering for patients. When the white count goes low, particularly neutropenia, that creates a risk of infection, as well as delays in chemotherapy that actually can help people. The supportive care use, GCSF, has its own side effects and expenses. Anemia causes our patients to be fatigued and short of breath, as well as requiring transfusions. And then, of course, if platelets were to go low, you can have a bleeding effect, although that's actually quite rare in clinical practice. So the idea here was that chemo works by killing cancer cells while they're dividing. Most of the healthy cells in the human body don't divide and so aren't affected by the chemotherapy. Most of the side effects that we have are in the cell lineages in the body that do have to divide to do their jobs. In this case, the bone marrow progenitors that make our white cells, red cells, and platelets. And so in each of 3 individual randomized phase 2 studies, we've seen a myelopreservation benefit. The first was the O2 trial, which I had the privilege of being involved with. This was the then standard of care for frontline extensive stage small cell carboplatin and etoposide, either with or without Trilaciclib. While that study was being done, the standard of care evolved to include atezolizumab, and so the O5 study was conducted, carboplatin and etoposide and atezolizumab, either with or without Trilaciclib. And finally, our standard of care in second line is topotecan, and so the O3 study was a randomization of topotecan with or without Trilaciclib. Individually, each of the studies did show myelopreservation, but a legitimate concern that can be raised with randomized phase 2 studies is whether if there's a safety signal, you have adequate power to tease it out. And so the data were combined to look at this. What the combined data showed was a decrease in severe neutropenia, the primary endpoint of the combined analysis, from 52.9% to 11.4%, a decrease numerically in febrile neutropenia from 9.2% to 3.3%, a decrease in the administration of GCSF from 56.3% to 28.5%, reduction in grade 3/4 anemia, reduction in transfusion, reduction in ESA use, reduction in thrombocytopenia, right? So in summary, all the lineages that you were looking to protect were in fact protected, and the downstream consequences of those in terms of supportive care requirements also decreased. So here, normally when you add on another drug to a regimen, the question is, okay, you got this treatment advantage, but at what cost to safety and toxicity? Here, the question is very much the opposite. This is not a drug designed to improve survival. This is a drug designed to decrease the side effects of chemotherapy. And so it's a negative safety signal, which is to say that the safety profile with the use of Trilaciclib looks better than without. Now, a natural skeptic's question is, okay, but was there any cost in terms of anti-neoplastic efficacy? The survival curves are completely superimposable with a hazard ratio of 1. The PFS curves are not quite superimposable, but there's certainly no harm. The hazard ratio, if anything, points in the right direction. It favors Trilaciclib with a hazard ratio of 0.8. Importantly, that was not statistically significant, but I would say that it pointing in the right direction makes me even more confident that there is not a harm to progression-free survival there. Now, the final skeptical question that you could ask would be, okay, you've improved the numbers, you've improved the use of supportive care. Do patients actually feel better? That's, of course, the real point of decreasing toxicity is quality of life. And for that, I would refer you to our presentation at MASCC, and there'll be a forthcoming manuscript about that as well.